In today's presentation on the healthcare guidelines for people with spina bifida, Dr. Nye will review the best practices in healthcare for adults living with spina bifida that were outlined in the Spina Bifida Association Guidelines for the Care of People with Spina Bifida that was published in 2018. She will discuss which healthcare professionals you should see on a regular basis and touch on the preventative care for sustaining good health when living with spina bifida as an adult. Dr. Nye is a med-ped specialist at the University of Cincinnati Hospital, where she works with all ages, including transition age and adult patients with intellectual and developmental disabilities. So I'm going to turn it over to you, Dr. Nye.
All right. Hey, everybody. Thanks for having me today. I think I said this, but not everybody was on at the time. So when I designed this presentation, I sort of envisioned some discussion if people had questions. So if you have a question as we're going through, feel free to pop it in the chat, and Diane hopefully will help me out with the chat. And then if you'd rather unmute yourself or you feel comfortable unmuting yourself and asking a question, then I hope you do. I'm happy to talk. And if there's a question that I can't answer, I will get your information and get it back to you. Okay. All right. So here we go. So this is the objectives for the day. Is we're going to make sure we run through building your adult healthcare team. Do we need to talk about transition? So I'll ask you that again in a minute, but think about it. Whether you're one of these people where we need to spend a little time. I do have a slide on it. We can spend as little time as we want on it, or if we need a little more, we can make some more time for it. Coordinating your care and advocacy in the healthcare setting, talking about prevention, and also talking about care by specific body systems. And I organized it this way because it's easier for my brain to think about individuals with complexity by system. And so that's just, and also the guidelines are more or less organized that way as well. Here we go. All right. So your healthcare team, these are the people generally that needs to be on your team. You need a primary care physician. And I know, I don't know you guys personally, but I know sometimes the primary care doctor does a little bit less in the pediatric years because you're coming in to clinic regularly and you're seeing a multidisciplinary clinic, especially if you grew up in the children's system. You're coming in fairly frequently. You're seeing all your specialists there. You have the developmental pediatrician there. Occasionally, I know they give some vaccines there, although I think they've been moving away from that here lately. And so in adult world, it is really, really important that you have a primary care doc. And I'm saying that with some bias because that's what much of my life is. I am a primary care doc, but boy, do I manage a lot of stuff for my patients with complexity. And I'm usually the first call before the specialist. You need a urologist. I don't know too many individuals who have spina bifida that don't need a urologist. So I just put them right on up there. I am a strong advocate for having a physical medicine and rehab doctor. So that I think that they generally are just extremely useful at ensuring we watch for overuse injuries, ensuring mobility supports are in place. I think they do. They're just, I love them. And I wish we had more, but we'll get to that in a minute. Neurosurgery. If you have had a shunt, you absolutely need a neurosurgeon. We'll get a little bit more in depth in that. If you are not a male, I recommend that you have an OB-GYN in your life. If you are a male, you do not need one. And then orthopedics kind of shifts in and out for specific issues. So whereas you might have seen ortho frequently in peds clinic, you may not need one as an adult, except for if something specific arises. All right. Clicking the thing. All right. So next up, transition. Please don't be an ostrich. How many, you can put it in the chat or unmute yourselves. How many of you are in process of transition or before the process of transition? Or are we done? Yeah, still working in some instances. Okay. So planning is your best friend. Don't stick your head in the sand and pretend like it's never going to happen. That's why we have an ostrich here. The internet has a lot of great pictures. So if you are in this planning process, it is so much easier to discuss transition with your pediatric team if you're not 45, right? It's a lot easier if you're a little bit younger, because I think what a lot of people fear happening is that you are, 30 or 40 years old, and you say to your pediatric provider, when do I need to move to an adult provider? And then they look down at your chart and they say, oh no, you're an adult. You should really have already moved on. It's a little bit scary when you're a little bit older to have that conversation versus when you're 12, 16, 18 years old and you're saying to your pediatric provider, what's the plan? Now you have some years, hopefully, to plan it out and think through, okay, this is the self-management skills that I need to achieve on the way to becoming an adult and kind of moving into adult care. These are these specialty care providers that I'm going to need to transfer for. And I know my specialty care providers' policies around how long they'll keep me and when I need to move on. And I know who they like. And so doing that ahead of time planning really, really does give you a chance to take into account what you need to do. It gives you a chance to plan around some of those expected life changes that are going on, right? So there are periods in our lives where we know we're going to have changes. You might be moving out of high school into a work situation or a college situation, and those are pretty stressful times, and you may not want to change your whole healthcare team right then and there. You may have to, if, say, you're moving across the country, right? But if you can try to stagger those big changes so that they're not all happening at once, that can be a lot less stressful for you, and a little bit less likely that, a little bit more unlikely that things fall through the cracks, right? We want to make sure things don't get missed and that you don't lose out on healthcare needs. I put one sentence here, but I could talk with you for months on this next one, that there are differences between the pediatric and adult healthcare systems. So there are some stereotyped differences that are maybe not always true. And there are some real differences that are generally pretty true. And so some of those stereotypes that are out there, as we talk about how pediatric providers are pretty touchy-feely and sweet and caring and huggy, and that maybe adult providers are not. That's not true for all of us, at least. They're individuals just like everywhere else. I can be, sweet and warm and fuzzy sometimes. And if you catch me on a bad day, I might not be. And so, and certainly I know pediatric providers that are not warm and fuzzy. So it goes both ways. There are some other differences that I think are important, that pediatric healthcare systems are geared toward making adults, right? They're geared toward health and prevention all the time. And so while certainly many of you have likely experienced some sort of medical issue over the last couple of decades, there's also so much that goes on in pediatrics around prevention, right? So there's all of the PT that many of you have probably done. That's both about skill acquisition and prevention of injuries and loss of function. All the vaccines that you got from the time that you were born all the way through, now, that's all about prevention and keeping you healthy. All of those child checks where we talk about, nutrition and all of those kinds of things. In adult healthcare, especially when we're talking about specialty care, a lot of the care is centered around a problem, right? An issue that someone is having that needs to be monitored or addressed.
Something to share about that. She said she has an adult primary care physician, but she's not established with a lot of the specialists. But when she needs them, then her primary care refers her for when she has a need.
Oh my gosh, you walked right into my playbook. So I love that. And I think that's really important. And that's just another plug for why having a primary care physician who you trust is really important, and someone who's willing to work with you. I will say that as a primary care physician, and I do care for individuals with spina bifida in my practice, If I send you out to a specialist, let's say you need a urologist and the person that you saw is too far away. You didn't feel like they listened to you, something, right? There's something that didn't go right with that. It's so important to me that you come back to me and say that so that I can say, okay, is this a thing? Like, do I know this person well? Where they may be having an off day and I'm going to coach you a little bit and say, hey, just give them one more shot, please. Or if it was singularly awful or maybe it's just not a good fit, then I say, all right, let's find someone else and we work on that together. And so using your primary care doctor as a referral source is fantastic. What I hope, particularly for really complex issues, and so one of the ones that comes up a lot for me is urology, and we'll spend a little more time talking about urology care, is that the pediatric and the adult providers, where possible, talk to each other, right? They, like, the urologists should speak urologist to each other. They have their own special set of things that they're always going to be thinking about and looking at. That's maybe not what I'm always thinking about as a primary care physician. And so you want your specialists, if possible, to speak their specialist language to one another. And then, again, the intention of all transition planning and basically all of your care, but for transition, should be all around maximizing independence and self-efficacy. And so we never want to put you in a situation where you feel like we're reducing your independence or we're reducing your ability to advocate for yourself. And if that's happening, hopefully you've got a great primary care provider who can help you negotiate that, or you work with your other members of your care team, whether that's a family member who's a support person, touching base with your pediatric providers, whatever works for you guys. Before I move on, because this is really truly my only transition slide, does anybody want to talk some more about transition or about a specific topic? Or do you want me to just keep moving and you can tell me later? I'm getting a lot of shrugs and a lot of maybe not, and a couple of people avoiding eye contact. Okay, I'm going to move on. So coordinating your care. This is another big difference between pediatric and adult care, especially if you go to a program where you have a big program like we have at Children's. You and your family become your care coordinator, meaning you've got to keep track when you have to follow up with your different people. So some of those discussions that need to be had as you see your different medical providers are going to be, how often do I need to be seen? As a primary care physician for my more complex patients, I typically say, hey, we need to see each other at least every 6 months because there's enough that's changing that we just need to touch base and catch up. If we have a problem that's going on that I need to address more frequently or monitor more frequently, and so there's loads of examples of that, right? I can come up, diabetes, blood pressure issues, if you're having wound issues, any of that kind of stuff, I might say that I need to see you more often. And that burden of keeping up with your specialty care will frequently switch over to you as well. So you may see, a specialist and they say, hey, come back in a year. They're probably not going to reach out and remind you a year from now that you're due to come back. It's on you to make sure that you do that. As your primary care doc, I would say, hey, I see you haven't seen so-and-so for 2 years. You need to get back in, and I'll give you their phone number and remind you. So again, back to having that really solid primary care situation. But just making sure that you're keeping up. And there's a lot of different ways to do that. And I have some ideas for you on the next slide. I think the other thing about how often do you need to be seen is what are the requirements in order to be able to access different kinds of orders, medication refills, DME orders, any kind of supply orders. Some of those have insurance-driven requirements that I'm signing a piece of paper that says I've seen you in the last 6 months and I know what's going on. Some of those may be provider-specific. If I'm giving you a medication where I need to monitor labs, I may say to you, hey, we've got to actually see each other every 3 months and do labs, or we've got to, get labs done before I can do the next refill, but maybe we don't need to do a visit. So working with your team to kind of just understand how often you need to be followed up to get everything done so that your life continues to operate smoothly. do you know who to call for different kinds of problems? So I said this earlier, I at least alluded to it, is that frequently the first call is going to be your primary care doctor in adult world. Unless there's been some specific discussion, and occasionally, I've had a patient who knows that if they're worried about their shunt, that their neurosurgeon wants to be called first. And occasionally I've got a patient who knows that if they're worried about their shunt, they want you to either just go straight to the ER or they want you to call me first. And so we work through whatever the issue is and do the appropriate diagnostics. Or, urinary tract infection is another great example. Sometimes it's hard to get a hold of your urologist and you end up calling primary care for orders for testing. So there's just working primarily with PCP. And I'm sure at this point, for the most part, you guys all know exactly when it's time to go to emergency room. So I'm not going to spend any more time on that one. For coordinating your care, how do you keep track of everything? So a lot of healthcare institutions, if they're on an electronic medical record, have some sort of patient portal. The product that goes with what we use here at UC and Children's, and actually in many of the hospital systems in this city, is called Epic, and the patient side is called MyChart. MyChart is fantastic because it tells you when your next visit is. You can see your old after visit summaries from your different care visits that kind of should indicate when you're due for follow-up. One of my favorite things about MyChart, because I love healthcare prevention things, is you can see your list of things that you're due for as far as healthcare prevention. So for example, if you were my patient and you looked in your MyChart right now and you haven't gotten your flu shot yet this year, it would show you that you're due for your flu shot. So that's a kind of nice tool. A lot of people, I have people who use web-based calendar systems. So like just regular Google Calendar to keep track of stuff. If I said to you, hey, follow up with me in a year, but you know that it takes a little while to get back in, like maybe it takes 3 months to get in once you call to schedule, then you might set yourself a calendar reminder 3 months ahead of time to say, hey, call to schedule with Dr. So-and-so. Some people use plain old-fashioned pen and paper calendars still. I am one of those people. I cannot fully switch to digital calendars to remember everything. So just whatever your system is, know it, love it, and stick with it. Okay. Or if you don't have a system, it's time to start working on one. And then identifying your supports, right? Ensuring that your emergency contact people and release of information, contact information is in the system wherever you're seeing folks. So I love MyChart too. MyChart is awesome. It is so helpful for me to message physicians, schedule appointments, and view test results. I agree wholeheartedly. I have some pretty active MyCharters in my life. They send me messages, and I think it's nice because it gives you an opportunity to think through what your question is. So, right, because it's different from being on the phone. It gives you an opportunity, if you're sitting at home, it's 2:00 in the morning and you just have this question that you need to ask, but it's not an actual emergency. You don't need to know right now the answer right now. That's a great option. You can just kind of basically like firing off a secure email. It is firing off a secure email. And you get your question off your chest. Your provider usually gets back to you within a couple of days, and then you've got your answer. You can see your lab results at the same time that your provider staff can see it. And then you can schedule appointments, which I recently delved into the world of scheduling for myself on MyChart, and it was amazing. It was so much better than waiting on a hold tree. So back to the release of information documentation, that's really helpful because sometimes adult healthcare tends to be pretty strict about who we talk to about your stuff. So, I'm not, and for good reasons, right? We shouldn't be disclosing your personal health information to people we don't know whether or not it's okay to talk to. So making sure that you've communicated to your provider and that it's correct in the chart. I actually came up with one of my patients, I was updating it yesterday, and it had information that was 4 or 5 years old on it. And so I was so glad that we took a minute to run through that together, because it had changed pretty significantly. We needed to make sure that it was all correct, so that we knew who to call, A, in an emergency, and B, if we couldn't get a hold of him for something. All right, self-advocacy. So this is my pump you up moment. You may need, so first a warning, you may need to spend some time educating new healthcare providers that you meet. I'm sure some of you have experienced this in life already, that you've had to educate somebody about what spina bifida is and what it means for you specifically. And so that being said, this is my moment of encouragement. You are an expert in you, right? There's only one you. And if you are having symptoms that are concerning for something, share it. For example, if shunt dysfunction, the signs of shunt dysfunction in adults and older teenagers can be really subtle. We learn in medical school about pediatric patients and what they look like and how they've changed. And that's, I think, for a lot of people really stick. But for you or your family, it may be as subtle as some personality change or a headache that's not going away. That's maybe not severe, but it's there. And so just knowing, if you've had this before and you know what it is, just fine to say, I've had this before. I know what it is, or I think I know what it is, and this is what I'm worried about. You should feel empowered to do that. And your team, this is part of building a team that works for you. It should be able to apply your personal expertise within the context of their medical training, right? So that they should listen to you. That's a nice way of saying that they should listen to you. Because again, you know what your signs are of stuff. I have, if you have more leg spasms when you have a urinary tract infection, if any of that kind of tip that may not be obvious to everybody around you, but is obvious to you or obvious to your family, share it if something's going on. Prevention.
There are some tools, and I can share those with the group. There's like a page that you can fill in and take to a doctor's appointment with you, so that it gives you the opportunity to kind of think about what you want to tell them in advance about yourself, and then you go and you have all of that information to prompt you to share that. And then also we're working on a tool that you would be able to take with you for hospital stays, or if you have to go to the emergency room, so that if you have to be inpatient, there might be things that make you more stressed, or we all know most of us are hard sticks. So like letting them know, listen, I'm a hard stick, bring in the expert. I don't want to be, tried 6 times for that. So that should be coming in the next year. But in the meantime, there are some other tools, and I will share that on our Facebook page.
Yeah, that's amazing. And that's super helpful. And I will say that I love getting those sheets of paper from families. And honestly, even if they're 20 pages long, I can skim a 20-page document for the stuff I need. That's no problem. And then go back and read it more deeply after the visit. I will take your information if you hand it to me. It's super helpful to have. All right, prevention. This next section is all about prevention and staying healthy. I've already told you I'm a fan. Exercise. So important. So the goal, and this is a goal from the United States Preventive Task Force, is that people get 150 minutes of moderate exercise per week. That's, 30 minutes 5 times a week. It's 50 minutes 3 times a week. It's, spread out over 7 days, whatever works for you. And that moderate intensity exercise, you should feel a little out of breath and sweaty. Okay. I put a website in here that has some great exercise resources. So benefits. Primary care doctor over here, I talk a lot about healthcare prevention, improved cardiovascular health and prevention of cardiovascular disease. So it helps with cholesterol management, blood pressure management, insulin issue or insulin resistance or diabetes. All of those things are things that we want to avoid in you, if at all possible. And I have seen folks go from not exercising to doing this 150 minutes a week, and I've seen them shave their cholesterol down and come off of blood pressure medications and be able to stop some diabetes medications. So exercise is so, so important. Also, exercise is good for helping people sleep. So if you have sleep issues, routine exercise has been shown, like, for real, not me just saying this because I feel this way, has really been shown to help people with sleep and help people with mood. So it helps manage anxiety and depression symptoms. I put a plug in for the walk and roll, even though I missed it this year because I was working. Sorry, guys. All right. So other routine preventive screen that should be done for all patients. So this is where your primary care doctor comes in. So you should be getting hypertension screening. You should be having your cholesterol screened if you're old enough. Obesity screening and screening for complications of obesity, diabetes screening, depression and anxiety, screening for tobacco, alcohol, and drug use, hearing and vision screening. I know I'm going through the list, but I used an abbreviation I shouldn't have. Sexually transmitted infection screening, as well as sexual health counseling. And then if you're a woman, if you're a woman, cervical cancer screening, everyone colon cancer screening, specific to spina bifida, so I don't forget to mention it. There's additional recommendations around bladder cancer screening. And so your primary care doctor should be monitoring and screening for complications specific to your underlying conditions as well. All right, so we're moving on to specialty-based stuff or system-based things. And so I started with neurosurgical needs because this is one that's been a hot button topic here in Cincinnati over the years. So if you have a shunt, a functioning shunt, I do recommend that you have a neurosurgeon in your life. And I already said this before, so I'm not going to spend a lot of time on it, that symptoms of shunt malfunction can vary amongst individuals. I put some common symptoms, and then included a link to a fact sheet that SBA has made. It's a 2-pager. It's got one page that's got kid stuff on it and one page that's got adolescent and adult stuff. So you only really need the second page. But I swear there's adult information on there. So the reason that I say that neurosurgery has been a hot button topic around here is that sometimes the counseling that we've provided over the years around transition for neurosurgery is that the adult neurosurgeon will kind of see you once and say, hey, if you need me, I'll see you again. That is not what SBA advocates for. What they advocate for is that you have somebody that you check in with once a year. And I'm happy to report that that's been the trend here lately with my neurosurgery colleagues. And so I've been happy to see that change happening, at least locally here in Cincinnati. And so it's getting better. We'll say that. I actually have a couple of neurosurgical colleagues here that I communicate with frequently because I have patients for whom I need to communicate with them frequently. And they have kind of agreed that, yep, we need to at least check in with the physician's assistant, somebody who works in their office, or the surgeon themselves at least once a year or every other year. Other things that you need to monitor for that we need to not forget about. So potential for brainstem dysfunction, which can be related to a Chiari malformation. So early signs would be swallowing dysfunction, difficulty managing oral secretions, or stridor, which is that. Anybody want me to demonstrate stridor, what that sounds like? I feel like, okay, it sounds like this. Ready? When you breathe in. So it's kind of comes from the vocal cords usually, or someplace around there. And if you're a kid with croup, I guess, closing in your airway. But usually for this situation, it's about the vocal cords. Tethered spinal cord can happen at any time. So even if you've had a cord release as a child, it could still tether. So back pain, new urologic dysfunction or changes, worsening sensory motor dysfunction are all potential signs of tethered cord. And then syringomyelia, these are tough because a lot of them are very similar. Back pain, sensory motor changes, so changes to how you feel or move in the arms or the hands. And so the big picture message that I want you to take away from this is that if you have a new neurologic symptom, so whether that's trouble swallowing, trouble with like new weird drooling that you've never had before, choking on your saliva, issues with breathing, new back pain, new problems with bowel and bladder, please, please, please call someone. Don't keep that to yourself and ignore it. If you have a neurosurgeon and they've talked to you about this before and it's part of the plan to go see them for any of these kinds of issues, then call them. Most people call their primary care first. If it's a sudden, acute, or severe change, you need to go to the emergency room. Okay. So just any questions on that one? I feel like neurologic things get scary. And so that's one that's really important. And if you're really having a big change and either you are worried or the people around are worried. Anybody have any questions on that one?
I don't have a question, but I just wanted to say it's helpful that I have a mom who's a nurse. She's been a nurse. So I usually I go to her first. This is just something that was on my mind.
Yeah.
I go to her first, especially with neurological and neurosurgical issues. I go to her first, and then usually I do reach out to my neurosurgeon, but
yeah,
away. But
yeah, well, and that demonstrates something else that I think is really important as we talk about getting older as an adult and being more independent. It's identifying your natural support people. I have plenty of folks who use their family to say, hey, am I talking slow, or is this weird? Or, does something seem different to you because I don't feel right? And frankly, that's true in all aspects of adulthood, regardless of underlying medical conditions, that having those support people in your life is really important. And also, like you demonstrated with your communication with your neurosurgeon, knowing the plan of what to do if something comes up, that you've got that nailed down pat, and it sounds like it works really well. So I'm going to move on to mobility and motor function.
I'm sorry, can I interrupt for a second?
Yes, please.
I had a question, actually a shunt question. I don't know if this is a simple answer or not, but you said if you have a shunt, or specifically if you have a functioning shunt.
Yeah.
Is there a specific way to tell whether a shunt is actually functioning?
So usually, if you don't have a shunt that's working, a neurosurgeon has explored it already and decided that they didn't need to replace it because, your cerebral spinal fluid is draining naturally somehow.
Okay. Well, I mean, I was recently evaluated for possible shunt malfunction, and the shunt series and CT scan and all that was done. Mm-hmm. And, my ventricles were not enlarged and the mm-hmm. shunt looked fine. So I didn't know if it necessarily meant that my shunt was still functioning and still doing what it was supposed to do, or if it was if my body is naturally doing what it's supposed to do.
So I would say, unless you've been specifically told by a neurosurgeon that your shunt is not functioning, but they're not going to do anything about it because your body is functioning how it's supposed to be, I would assume your shunt is in there and it's doing what it's supposed to do.
Okay.
Yeah. I would so unless somebody has told you, don't worry about this anymore, you should just keep assuming that you need it and that it's working.
Okay, because I had my first shunt placed when I was a week old, and I had it replaced when I was 11, mm-hmm. and that was 25 plus years ago. So that's kind of one of the reasons I was asking. Yeah. It's been at least 25 years since I've had a shunt revision or replacement.
Yeah, that's amazing. And so that's wonderful to have only had to be revised the one time. And some people are actually, as we move into adulthood, shunt malfunction seems to become less and less common, which is another reason why I spent so much time talking about it, is because when it does become less and less common, it's something that's important to be aware of. And so do exactly as you did. If you were having a concern, go get it checked out.
Yeah, because I ended up having a couple of seizures,
Yeah,
which
that's scary.
yeah, it was very scary, and no history of seizures or anything. And so that was honestly the first thing that they checked was
Yes.
the shunt. Shunt was fine. It ended up being medication. So anyway, that's one of the reasons I brought it up, is because I was recently evaluated for shunt malfunction because of seizures. So.
Ooh, that sounds like an adventure that probably everybody else would like to avoid if they can. I'm glad you're doing okay. So, and again, if, as we go, if there's something else that you guys, pops into mind that you want to talk about, just let me know, and feel free to interrupt. So for mobility and motor function, I'm going to strongly encourage everybody to, continue a relationship with a physical medicine and rehab doctor. For those of you who came up through the PED system here in Cincinnati, you saw a PM&R doctor pretty much every time you came into clinic, probably, or at least every 6 months or so. We do, I'm going to plug my colleague here. We do have a new provider. Well, she's newly back to Cincinnati with UC Physical Medicine and Rehab, Dr. Jazine Clark, who is in process of working with our pediatric providers and developing some transition processes. And so she's actually building some great supports into her clinics, which include some of the things that I feel like have been missing over time. So like just some one-stop shopping for resources in case you aren't connected to a primary care doctor or you aren't connected to some specialty care. She has the ability to help connect folks. But she also can continue to do that focus and has the training around preserving and improving mobility, preventing injury, maintaining flexibility, range of motion, all of those kinds of things, which are really important. We don't want people to have pain if possible, right? Nobody likes to have that. We want people to continue to be able to do the activities that they enjoy. One of the things that I always lump in with mobility and motor function is making sure we're keeping an eye on bone density. If you do not spend a lot of time doing weight-bearing activity, particularly in your lower extremities or your spine, you do run an increased risk for having low bone density, which can make it easier to break something. We do monitor a little bit differently for individuals who are wheelchair dependent, and make sure that we're keeping track of maximizing your bone density in any way that we can. And so that may be through nutrition, that may be through activities or mobility support devices. There's actually a lot of different ways to address low bone density. But what we're trying to do here is we're trying to prevent fractures. We don't want you to break anything. And pain, because when you break things, that hurts. All right, urologic care. We spent a little bit of time talking about urology already. A lot of urologic care is specific to individual needs, anatomy, and function, right? So I would be willing, if you were actually all sitting in a room, you could look at the person next to you and they may have a different urology plan or bladder care plan than you have. And you could look the other way and that person may have a different plan than the person on the other side of you. And so for most patients who do have spina bifida, you need a urologist in your life, especially if you require catheterization or if you've had bladder augmentation or any kind of bladder modifying surgery. I'm lucky to have a couple of, besides having the amazing pediatric colleagues that I've known for many years over at Children's, I have some adult colleagues here that are knowledgeable around some of those surgeries that we don't typically do on adults, like bladder augmentation and midtrophanoffs. And so I'm happy to have those colleagues here to collaborate with and ensure that my patients are getting the care that they need. think another important thing to consider for my patients for patients who cath intermittently is that you do need to do bladder cancer screening with your urologist as well. So it's an additional risk factor for bladder cancer. So we need to make sure we're keeping track of that. Typically, I tell people that they need to see their urologist at least once a year, especially if you're getting things from your urologist, right? Are you getting medications prescribed by them? Are you getting supplies prescribed by them? Sometimes it works differently in different systems. It may be your primary care doctor that's prescribing your cath supplies, or it may be the urologist. So just making sure that you're checking in. I also think that it's really important that you're having a discussion either with your primary care or your urologist at least once a year, but more often if needed, about your level of satisfaction with your continence. Are you having new accidents that you didn't have before? Is that a sign of a problem? Or is it a sign that something's changing in your body somehow and we need to figure out how to adjust your plan and help you have a better quality of life related to your continence? So this goes back to my self-advocacy slide. You know what's different for you. And if you're having a change, I hope you talk to us about it so that we can think with you on how to make your life better, right? Or make your life how you need it to be. Bowel care. I put my poop chart up here. Hopefully somebody's seen this Bristol stool chart before. Somebody actually did research on different types of poo. So there you go. It's for real research. So there are serious consequences to constipation and not doing your bowel regimen. So increased intra-abdominal pressure. If you have a shunt, that can cause shunt malfunction if your shunt is draining into your belly. It can cause urinary incontinence. So that's back to the last slide. If you're not happy with your level of continence, one of the first things I ask is, how are things going in the bowel department? You can put you at increased risk for urinary tract infections if you're not treating your constipation. There's also consequences to diarrhea. So are we over treating you? You can have skin breakdown. You can have, diarrhea itself is not particularly fun, right? Because if you can't predict when you're going to have a bowel movement and you're out in the world and all of a sudden you have an accident, that can be pretty significant as well. In adult care, sometimes the bowel regimen is managed by a primary care doctor in conjunction with urology. I heard a rumor that Diane spread to me that there was maybe somebody in urology who is going to start to take on more bowel management. I'll let Diane know once I figure out who that is, and she can share it with you. And again, annually, you should be talking with somebody, whether it's the urologist or your primary care doctor, how happy you are with your level of continence. I think most of us can work with you creatively to find a better situation if you're having more accidents than you would like, or if you're having smearing, which could be a sign of constipation. So we can run through that troubleshooting with you and hopefully adjust things to make life better. All right, this is the one where everybody blushes and tries not to make eye contact with me. We're going to talk about genital care a little bit and sexual health. Annual genital urinary exam, or GU exam for short, with your primary care doctor or your urologist, which should include an assessment of sensation. And you should assess and treat for any erectile dysfunction, and discuss prostate cancer screening and assess for risk factors. And I put discuss in there in all capital letters because it is truly a discussion. The guidance around prostate cancer screening for men has changed pretty significantly in the last decade or so. It changed because the way that it was written before, where everybody had prostate exams, which is it's a rectal exam to feel the prostate gland, and got testing all the time with blood tests, that actually resulted in a lot of unnecessary prostate biopsies and a lot of discomfort and missed life because you're having these procedures. And so now you should be discussing with your urologist or primary doctor whether or not you want to get the blood test to look for prostate cancer risk. Everyone, see how I did the continuum here. So for everybody, you should be talking to primary doctor, your gynecologist, your urologist about sexually transmitted infection prevention and screening, and also counseling on pregnancy prevention or pregnancy preparation. I should have put that both ways, and other fertility related concerns. For women, you should be having an annual exam done with accessible equipment, right? It doesn't make sense if you can't get on the table to do this. You should be doing routine gynecologic care, including pap smears and mammograms at age-appropriate intervals. So for those of you who have not yet reached that age, you're fine. But for women right now, as the guidelines are written, you should have a pap smear every 3 years starting at the age of 21. And so that's a very specific kind of gynecologic exam where it's a pelvic exam, but it's with a specific test to collect cells from your cervix. This is for cervical cancer screening. And it gets sent off to the lab and they look for abnormal cells. At the age of 30, we frequently will switch that screening to every 5 years, and we also will add in some additional testing around the virus that most commonly causes cervical cancer. And then those guidelines are going to change probably in the next year, so more coming on that one. But that's what they are right this second.
And Dr. Nye, there are some primary care physicians who are willing and able to provide that care for their patients, correct?
Yep. Yes, absolutely. You do not have to go to a gynecologist necessarily. And so I absolutely do well woman care for my patients. Sometimes where we run into trouble is if for some reason the equipment is not going to work properly, the gynecologists actually have some specialized equipment to help with supporting lower extremities that aren't always available in every office. So it may be like you try it with the primary care and see if we can't make adaptations. And then if that doesn't work, we send you to the gynecologist. And then mammograms, I'll just spend 1 second on mammogram recommendations as far as getting breast cancer screening are based on age, but also based on your family history. So you should be talking to your gynecologist or your primary care about that. There are increased risk for pelvic floor problems in women with spina bifida and pelvic organ prolapse, which is essentially meaning that things kind of fall out. And so if that were to happen, you do need to see a specialist, a gynecology specialist, for treatment of that. And it's related to for individuals who have motor level that's above the pelvic floor, basically. So meaning that that part of your body is affected. You can have weakness in those muscles and they don't hold things inside as well as you'd like them to. Okay. Does that make sense for the most part? And then preconception counseling, for women who are interested in becoming pregnant, what the recommendation is and what I recommend is having a visit with a OB, an obstetrician, who does high risk pregnancy management. Because individuals with mobility concerns are at increased risk for issues related to the shape of their pelvis and issues related to their skin with the increased weight of carrying a baby. I do recommend that you visit with someone before getting pregnant, if at all possible, to ensure that we're kind of running through with you what your personal risk factors are with regard to your medical conditions. Certainly, if you've had some bladder surgeries, there's some other considerations that need to be taken. And then, of course, we would like to make sure that everybody is taking their folic acid before pregnancy. Some people also will choose to visit with a geneticist, whether you are a man with spina bifida or a woman before pregnancy, to talk about risk factors related to passing spina bifida onto a child potentially, and how you might help prevent that, which, by the way, is with folic acid. Skincare. All of the old rules that you've had said to you forever and ever and ever apply still. All right. So you need to check your skin daily. You need to offload pressure points. I've seen people shift throughout the presentation every few minutes here, and so that's fantastic. And then ensuring that your support devices, whether it's an AFO or anything else, are not causing damage to your skin, because of course, if they are, we need to have them adjusted. And so most primary care offices do not have a lift to move patients onto an exam table. So sometimes skin exams can be tough. I will say though, plug for adult offices, most of us do have some tables that go up and down. Because certainly we see all different kinds of patients with mobility concerns. And no offense to people who are getting a little older in years. Sometimes older folks can't climb up on the exam table either. So we do have some tables in most offices that have a power switch to go up and down. But if you're an individual who requires a lift, that may be a little bit more difficult. I know of one office in the area, one adult office in the area that does have a lift, and I've submitted for one this year for our office. So hopefully it happens. Sleep is really important. I already alluded to this a little bit when the exercise piece. There is an increased risk for sleep-related breathing disorders for people with spina bifida. So when I screen people for these kinds of disorders, I ask if they have a history of snoring. It's usually my first question is, has anybody ever told you that you snore? And then my second question, when you tell me either I don't know, well, actually, if you say I don't know, then I can't go to my second question. But if you say yes, I say, has anybody ever told you that you pause or gasp while you're sleeping? And so what that sounds like is that pause and breathing and then a big breath in. And that can be a sign of obstructive sleep apnea. Other signs or symptoms could be morning headaches, waking up in the morning with a headache. Of course, now we're starting to get into some symptoms that cross over with shunt issues, but also daytime fatigue or falling asleep inappropriately during the day. So my question for that usually is, if you're driving in the car and you stop at a stoplight, or if you're riding in the car and you stop at a stoplight, while you're waiting for it to turn, do you sometimes nod off? That's a pretty significant, or if you're, in the middle of a conversation with somebody, do you sometimes nod off? Those are pretty good indicators that you might want to talk to somebody about a sleep study. Workup typically does require a referral to a sleep medicine specialist. Those people are usually a neurologist or a pulmonologist, a lung doctor by training, and ultimately they generally refer for a sleep study. The reason that treating sleep-related breathing disorders is really important is because they can lead to all kinds of other problems. So they reduce the quality of your sleep. So that makes it really hard for you to concentrate during the day if you haven't gotten a good night's sleep. It can actually lead to high blood pressure or make high blood pressure really difficult to treat. It can cause strain on your heart. So it can cause, in bad situations, can cause some heart failure. It can also mess with your mood and your concentration. And so those are not good things that we want for people. So if we're worried about it, we generally do recommend treatment and management for that. Mental health. I think that this is a really important topic to cover, and I particularly in the age of COVID and a little bit more isolation in the age of COVID, but always, annual screening for depression and anxiety should occur with your primary care doctor. Frequently, those are done with kind of a standard set of 2 questions for depression and 2 questions for anxiety. There's some validated screeners out there, and if those turn up positive, or if you tell me that you have a concern, we do more talking and more questions. Access to appropriate counseling resources is incredibly important. And it can sometimes be a barrier to seeking and obtaining counseling. Whether it's because of difficulties with transportation, because it's difficulties related to your insurer, whatever it is, I just wanted to admit openly that the healthcare system has some room for improvement on ensuring better access to counseling resources. Most primary care providers will manage medications if a medication is recommended for depression and anxiety. It's frankly quite a lot of what we do throughout our day. But occasionally a referral will be required for a psychiatrist, just depending on what's going on. And that's part of, again, that open and good communication with your primary care doctor. You want someone who's going to tell you, hey, I'm not comfortable with this, and I think we need to involve a specialist. And so you want to make sure that you have that comfort level on there. Oh, that was my last slide. Okay. So I love the things that have come up as we've talked today. And if anybody's got anything else, throw it in the chat, unmute yourself, whatever you want.
I think a question that someone has asked me was getting gynecologic care is not just dependent on if you're sexually active. Like, it's important, to still go and get that screening every year regardless. And I know it's one more thing for our young women to have to, or even middle-aged women to have to deal with, but it's important. And I don't know if you want to talk a little bit more about that.
Yeah, so I agree that it is important to get that gynecologic care lifelong, regardless of sexual activity. And so I do recommend that cervical cancer screening for people still starting at the age of 21. The recommendations are supposedly going to change to 25 because of the advent of HPV vaccines, which is HPV is the virus that most frequently causes cervical cancer. The reason that I recommend that screening still occur despite whether or not you've had sex before is because some HPV or human papillomavirus can spread through normal day-to-day life, not sex. We kind of glossed over but talked about the risk for pelvic floor prolapse or pelvic floor issues for women with spina bifida. That's also part of that process, is making sure that we're screening to ensure that we're not seeing early signs of that. And maybe we can help fix it before it's bad, right? And needs major intervention. Let's see. I would love to hear more about where you found your counselor who specializes in working with folks with coexisting medical issues. That's a really cool thing to find, and I'm glad you did. So if you feel comfortable sharing who that is, maybe with Diane and other people, if other people are interested, we're always looking for more resources to share with our patients. I collect good providers like trading cards. So
it for me wasn't in the state because I just moved here like a year ago.
Okay.
But I just found it helpful that they specialized in knowing. So I didn't go and they were like, Spina what? Because that's not always the most helpful when it comes to medical professionals. So
I agree.
I found it helpful that they already kind of knew what it was.
Mm-hmm. That's really cool.
And I think too, for me, like that's what I was struggling with. I think kind of an onset of, I had a surgery that didn't go well and I became more paralyzed as a result. And I think I just really struggled with kind of dealing with that. And so my primary doctor was like, hey, like this is a thing. Why don't you go see this person? I was like, okay, cool. And I thought that was really helpful to help me work through something that they were kind of trained to help work through.
Okay. Thank you. Well, if I find anybody, I'll update Diane so that I'll share my trading cards with her.
Super. I'd love to share the information with our folks because I know there's a lot of interest, and it's can be very difficult to find the right person, and you might get through 2 or 3 before you find a good fit.
And that's actually a great kind of transition point too, is that I talk to people as they're looking into new providers, whether it's a mental health provider or a doctor or an NP or PA, whatever, is that I talk about it a little bit like dating. Some of you have dated probably before, but you go out on a first date, and if it's okay, right, you might go on a second date. And if you go on the second date and it's, still okay, you might go on a third date. But if you're on your third date and you're still not really jiving, it's probably time to be done, right? Don't go out with that person again, especially if you're paying. Just kidding about that part. Don't waste your time. With doctors, similarly, your pediatric team has known you forever and ever and ever. And so you meet a doctor for the first time, they're not going to know everything about you. So in that respect, it's a little bit like a first date, right? Except no romantic stuff. If it's okay, give them one more shot, right? Go back again, see if it gets better. If you're getting to your third visit with a doctor and you're not clicking, then probably you should be looking for another doctor that kind of fits a little bit better with what your needs are. That being said, the thing that is different between dating and seeing doctors, besides the lack of romantic pieces and probably dinner, you don't necessarily want to fire your doctor until you've found a new one, right? You want to make sure that you've got someone still that can do your refills or order supplies or whatever. So you wait until you've established with somebody else that you trust before you tell your other provider, hey, I'm not going to come to you anymore. Because we want to make sure that we're keeping those needs for you covered and that you're not getting gaps in orders, whether it's med refills or whatever. I do recommend, though, that if you're dating somebody and you want to break up with them, that you don't keep them around until you find somebody else. That's probably not super healthy.
I've heard some people who've had unhappy experiences at an institution, and so will no longer even investigate any physician there. And I know there's such a limited number of people that we can refer to.
Yeah.
Is there anything that you can advise there?
Yeah, and so I
think particularly like if they're inpatient or in the emergency room, it doesn't go well, and then they say, I don't want to see anybody there.
Well, so and especially if you've been in basically any emergency room in the last, 18, 20 months, things have been a little rough, right? And so I think similar to how I want you guys to be viewed as individuals with individual needs, I think I hope that you envision or kind of view your healthcare team as individuals as well. And so I have patients who absolutely refuse to go to certain emergency rooms because of something that happened. Sometimes it's justified and we can work around it. And sometimes we can't. So if you have an awful experience in a hospital, I hope you talk to the patient services people and tell them about your awful experience and why, because that's a learning opportunity for that institution, whether it's mine, whether it's children's, whether it's any other system. That's a learning opportunity, and hopefully they choose to use it as such. I honestly encourage my patients, even if it's for my own institution, to talk to those folks. I have a parking situation that is not ideal around here. And with that, I had enough people who called and complained that I got a meeting with the parking services people to talk about how we're going to fix it. So it does help make changes. Whatever the issue is, I think one of the issues that I've heard that always kind of makes me boil a little bit is that, and actually I've heard it in multiple hospital systems, is that somebody looks at an individual who is in a wheelchair, and instead of speaking to that individual, they speak to whoever is with them, right? We've all heard stories about this happening. It's atrocious. It shouldn't happen. When I teach residents and medical students, I teach them to speak to the patient first, always, regardless of what you already know about the patient, because that's just the right thing to do. And man, what if we're all wrong and somebody who doesn't talk to me can actually understand absolutely everything I say and I've just not addressed them first? That would be bad. I think if that's happening, that somebody needs to hear about that, because you may make it better for the next person, even if you never go back. I have had patients who have been to see a specialist and had a rough time, didn't like them for whatever reason. They didn't click. They didn't feel like they spoke directly to them. And we've addressed it on an individual basis. For one of them, I actually reached out directly to the specialist that they had a concern and said, hey, talk to my patient. They said that this happened. And I'd really love to support you in helping to improve the experience next time. Would you like to have a discussion about it? And it actually worked out really well. We had a phone call. We talked a little bit about it. They felt horrible about how they made that individual feel and their family. And they changed how they interacted with that person. They've since been back several times and they've been very happy. And so it stinks to have to be the person who leads the change, right? That always kind of hurts. And I don't want you guys to be in situations ever where you're having that uncomfortable or frankly ableist attitude. But if it does happen, I hope that you speak up either in the moment or later with patient services and tell them. If you have a institution that you never, ever, ever want to go to, but that's the only place that there's a fill in the blank specialist that can help you, that happens sometimes, right? There's one cardiologist in town that does this one thing and that's the only available person. We need to work on that together, or you need to work on that with your primary doctor about kind of what your fears and what can happen, because you may really only be able to go to that person. And if we can do some planning on the front end, let's say the bad experience happened in the inpatient part of the hospital, we should do it, right? I will, for my complex patients when they come into the hospital, and sometimes for my less complex patients, if they're have other reasons to have some challenges being in the hospital, I will frequently reach out to the hospitalist that's taking care of them and say, hey, this is my patient. I know them super well. Here's some things I'm worried about with this admission. Here's my phone number. Please call me if you have any questions or concerns. I'll be checking in on their chart on a regular basis, and I may pop up to say hi if I have time. So just having that collaboration with the inpatient to outpatient team, something that I think medicine has moved away from as a field in the last 15 years. But we're getting better again. It's a pendulum that swings back and forth. We're getting a little bit better again, and we're getting recognizing the importance of transition between inpatient, outpatient, ED, and outpatient, and how to better collaborate on that. So we're working on it, I promise. But have a primary care doctor that's a good advocate for you.
Well, I'm going to speak up and say this. I'm having difficulties right now because my employer is changing insurance companies. I have to start all over with everybody come January. Instead of being able to go to someone at Mercy or UC Health, I'm restricted to TriHealth, and I don't know what the fourth one is, Christ or whatever they're affiliated with. And one of them was our claim experience. But I guess Mercy and UC Health is really expensive. And I just went to see a colon doctor. I went to see one, and we weren't a good fit. I told Diane about this. I asked him if he'd ever treated anybody with spina bifida. He said, no, I went to high school with somebody who had spina bifida, though. So that wasn't a real good experience. And then I went to the other one who, and so the first doctor cost me out of pocket $176, who did a visual exam, and that was it. The second one did some more things, but he didn't like what my thoughts were. I guess in a way he felt like he was wasting his time with me. In a way, I kind of got that. But my cost with him was $504. Wow. My out of pocket. So I'm a little nervous now about starting over, and I haven't had a gynecologist in a while. I haven't had a urologist in a while because the cost is just so high. And so I'm having to change primary care physician too. He's with Mercy. So I kind of, even though I'm not transitioning, from teen to adult, I am transitioning to all new doctors. And I even asked them, do you think maybe the year, next year we'll go back to Anthem or Aetna or whomever? And they didn't seem too confident in that.
So I will say sometimes with insurance changes, you can appeal your insurer for providers, and your grounds would be that you have a medically complex history, and it would be detrimental to your health to switch all your doctors and to ask them to add those individuals to the plan.
Okay.
That is an option, and you can work with your HR around that. The hard part is that if they ultimately say no, then you still have to switch. But the worst thing that happens if you ask, right, is that they say no. I don't think you're gonna, you shouldn't have any other negative potential outcome from asking if it's possible. And probably the other one would be you'd sink a little bit of time in appealing, doing some paperwork to appeal. And
Okay.
you would just be asking for them to make special dispensation for you. And so I would try that, because I mean, you've already probably switched from pediatric providers to adult providers at this point. It's a big process, and it's a lot of work, and those people know you. And if you trust them, it's an issue, right? And so that's adult insurance. Adulting is hard sometimes. So all the insurance is tough to navigate. And you need a PhD in it, I think. In fact, there are people who actually go on to get PhDs in understanding the American healthcare system. Yeah, I'll leave it there. On that depressing note, I'll stop there.
Well, that's good advice, though. That's something I would not have thought to do. Thank you.
Mm-hmm.
Well, Dr. Nye, thank you for staying on for a few extra minutes and helping to answer some questions. Is there anybody else that has a pressing question? Okay, well, I think we need a break before we go on to our next session. All great information. So thank you so much for sharing those tips with us today, and how to go about getting through to the providers that you need and advocating for yourself when you get there.
Yes, thank you.
Thanks, everybody.